Good morning. Let's talk on phenylketonuria. It is a genetic disorder. It's an inborn errors of metabolism and is characterized by complete lack of hepatic enzyme phenylalanine hydroxylase, which normally converts phenylalanine to tyrosine. This disorder causes the impairment of postnatal brain development, resulting in a severe mental retardation in untreated children. So this phenylalanine in this case is not able to be converted to tyrosine because of this lack of enzyme. So this is the classical manifestation of disease if this enzyme is lacking. Beside this enzyme requires the molecular presence of tetrahydrobiopterin, which also requires the NADPH, a molecular presence of NADPH. So in course of this reaction, the tetrahydrobiopterin turns to dihydrobiopterin, which again reverts back to tetrahydrobiopterin in the presence of NADPH, which act as a reducing equivalent. So if the enzyme is lacking or if the this uh, enzyme is lacking, both may lead to the manifestation, that is the phenylalanine is not able to be converted to tyrosine. So it results in accumulation of phenylalanine in tissues and blood, and it's increased excretion in the urine. It is an autosomal recessive disorder. It happens one in every 10,000 to 20,000, 25,000 births. So, classification of phenylketonuria, as I've already told you, the classical phenylketonuria is due to the lack of this enzyme phenylalanine hydroxylase. Besides, two atypical variants are also there. One is due to the deficiency of dihydrobiopterin reductase. So, if there is a deficiency, it will not lead to the conversion of dihydrobiopterin to tetrahydrobiopterin, which is a necessary coenzyme for this enzyme phenylalanine hydroxylase. The third one is dihydrobiopterin synthase. So, these are the various causes of phenylketonuria. In absence of phenyl hydroxylate, there is severe accumulation into the of this phenylalanine into the brain, into the blood and tissues. This leads to its conversion to various other metabolites in the form of phenylpyruvate, phenylactate, phenylacetate. So these are the various metabolites due to the accumulation and transformation of phenylalanine. So much of the phenyl pyruvate, rather than being excreted in the urine, it is decarboxylated to phenylacetate, and phenylactate imparts a very characteristic mousy odor to the urine, which have traditionally been used to detect the phenylketonuria. So accumulation of phenylalanine or its metabolite in early life impairs the normal development of the brain, causing the mental retardation. And this is the autosomal recessive inheritance stress. If both the parents are carrier having the one recessive allele. So the trend of progenies, four progenies out of four, one will be completely affected, two are carrier, and one is non-affected, non-carrier. So ratio is affected to unaffected is 1:3. So because in the carrier there is single recessive allele, so not no manifestation of disease. In the affected one, both the recessive alleles are available. So it's causing manifestation of disease, and one is unaffected non-carrier. So neurological symptoms are mental retardation, failure to walk, talk or to talk, seizures, tremor, psychosis in the form of agitation and hyperactivity, and failure to grow. So the mental symptoms are due to the phenylalanine because it is competing with other amino acid for transport across the blood-brain barrier, resulting in deficit of required metabolites. High concentration of phenylalanine prevent the amino acid transport of any of tyrosine present as well as tryptophan, because there is a same carrier transporters are available in the brain for both for tyrosine, tryptophan, and phenylalanine. So, due to the accumulation severe concentration of phenylalanine, so there is inhibition of entry of this tyrosine and tryptophan, which are responsible for synthesis of number of neurotransmitters. There is a lack of serotonin. Then hypopigmentation is another manifestation of the disease. So phenylketonurics have a lighter skin color, fair hair, and blue eyes due to the deficiency of pigment melanin. So hydroxylation of tyrosine by tyrosinase is the first step in the formation of pigment melanin and is competitively inhibited by the high level of phenylalanine, phenylketonuria. Laboratory diagnostic of phenylketonuria. The normal level of phenylalanine is 1 milligrams per dl. In phenylketonurics, the level is more than 20 milligrams per dl. So following are the screening test. First screening is a Guthrie test. The presence of phenylalanine in blood is detected by this particular test. The test is based on bacterial inhibition assay for phenylalanine by restricting the growth of Bacillus subtilis. Another one is confirmatory test we perform by chromatography. It can be tandem mass spectrometry or the GCMS or gas mass spectrometry. Prenatal diagnosis of DNA probes are also available. The gene for human phenylalanine hydroxylase has been now cloned, and so the prenatal diagnosis of phenylketonuria is now possible with DNA probes. Another test is urine of patient contains phenylketones, and in the past year, the urine of newborn was assayed by addition of ferric chloride, which gives the olive green color if the phenyl pyruvates or other ketones are present in the urine. Now, treatment of phenylketonuria as a defect lies in phenylalanine hydroxylase, the low phenylalanine diet supplemented with tyrosine because tyrosine is normally synthesized from phenylalanine, and if in this case it is not available due to the lack of the enzyme, so it is to be supplemented from the diet because it has many role to perform in the body. So tapioca based diet till 5 years of age to be given. The aim is to provide just enough phenylalanine to meet the need for growth and replacement. The treatment due to the defect of dihydrobiopterin reductase is more complex than restricting the intake of phenylalanine and tyrosine. Tetrahydrobiopterin is also required for the formation of L3,4 dihydroxyphenylalanine, that is L-DOPA, and 5-hydroxytryptophan, uh, precursor for the neurotransmitters norepinephrine and serotonin respectively. So in phenylketonuria of this type, these precursors must be supplied in the diet along with the tetrahydrobiopterin.